Okay, let's dive in. We're tackling something really fundamental today. Unsteadiness, trouble walking, and unfortunately the falls that often follow.
Right. These are huge concerns, especially as people get older, and they seriously impact quality of life.
Absolutely. And it's not just about inconvenience, is it? It often signals a deeper underlying problem.
Exactly. When a patient says they've lost balance or walking feels different, it's almost never random. An abnormal gait, well, it's usually a symptom.
A symptom of what, typically?
It could be motor weakness, maybe some sensory loss, incoordination, even movement disorders.
Mhm.
The way someone walks is like a printout showing where the neurological system might be having trouble.
So the first step is always a really focused history and physical exam.
Always. That's where you start picking up the clues.
And that's where our deep dive comes in today. We've got sources outlining 5 really distinct types of gait that can be powerful diagnostic clues right off the bat.
That's right. We're talking spastic, stomping, steppage, ataxic, and Parkinsonian gaits.
Our mission here is to help you recognize these patterns visually. If you can spot them, you can really narrow down the possibilities.
Precisely. It gives you a massive head start. So should we jump into the first one?
Let's do it. Spastic gait. The description for this one is pretty striking. Stiff legs, trouble lifting the feet. Poor floor clearance, I think was the term.
That's the core of it. Because they can't easily lift the foot and clear the ground, they develop this characteristic stiffness.
And that stiffness forces a weird movement, right?
Right.
Circumduction.
Exactly. Circumduction, they have to swing the leg outward in this sort of semicircle,
Yeah.
then bring it back in to take a step forward.
Almost like they're stepping around an imaginary obstacle.
That's a good way to put it. It's
Yeah.
this awkward, stiff-legged swing.
And here's a great little diagnostic tip from the sources. Check the shoes.
Yes. Because they don't lift their toes properly, the toes tend to scrape the floor with each step.
So you can actually see the wear pattern on the front or the tips of their shoes, a little scuff mark telling a big story.
It's a fantastic clue. And that stiffness, that scraping, it immediately tells you we're likely dealing with an upper motor neuron problem.
Meaning an issue with the signals coming from the brain or the spinal cord.
Correct. The pathway controlling voluntary movement is affected somewhere high up.
Okay, so if we see that spastic gait, what are the main conditions we should be thinking about?
Well, the sources highlight 2 big ones. First, especially in older adults perhaps, is cervical myelopathy.
That's pressure on the spinal cord in the neck area?
Yes, often due to things like spinal stenosis or maybe a herniated disc. The patient might report neck pain, maybe weakness or numbness spreading into the arms and legs.
And the exam clinches it.
Often, yes. You'll find that spasticity, but also hyperreflexia, those exaggerated reflexes. And importantly, it might be in all 4 limbs, pointing right to the neck issue. A CT or MRI of the cervical spine would then confirm the compression.
Okay, that makes sense. What's the second major cause?
So the second one is quite different in origin. Cerebral palsy.
Ah, so this is something starting much earlier in life.
Right. Here, the history is absolutely key. You're looking for evidence of an injury around the time of birth, maybe perinatal asphyxia, and typically delays in hitting motor milestones.
And potentially other things like cognitive delays or epilepsy alongside it?
Often associated, yes. The exam findings, the spasticity, the hyperreflexia, can look similar to myelopathy. It would be just in one side or both legs. But it's that history that points towards a developmental cause, rather than an acquired compression later in life.
Okay, moving from stiffness to, well, force. The stomping gait sounds pretty dramatic, heavy, forceful steps.
It is quite distinct. And what's fascinating here is why they stomp. It's not about muscle power, it's about sensation, or rather the lack of it.
Lack of sensation.
Specifically a loss of proprioception in their feet and legs. This gait is sometimes called sensory ataxia.
Proprioception. That's the sense of where your body parts are in space, right? Like even with your eyes closed.
Exactly that. If you lose that sense in your feet, your brain doesn't get the feedback that your foot has actually landed securely on the ground.
So the stomping is a way to compensate.
It's one way. They might stomp down hard to create a really strong vibration or pressure signal that their brain can register. The other way they compensate is by watching their feet intently as they walk.
Ah, okay. So they need that visual confirmation if the sensory feedback isn't there.
Precisely. Which leads to a key characteristic.
Let me guess. The gait gets much worse if they can't see their feet.
You got it. It's typically wide-based and unsteady to begin with, but ask them to walk in the dark or even just close their eyes, and the unsteadiness becomes dramatically worse. They might start to sway or lose balance entirely.
That's a huge clue then. It tells you the problem isn't primarily in the cerebellum, the coordination center, but rather in the sensory pathways.
Exactly right. It points us towards problems affecting the nerves carrying that position sense up to the brain.
And what kind of problems are we talking about? The sources mention some pretty serious underlying conditions.
Yes, this pattern pushes you to investigate for specific causes, often needing lab tests. First off, you'd check the hemoglobin A1C. If it's high, you're strongly considering diabetic polyneuropathy.
Okay, diabetes damaging the peripheral nerves. Makes sense.
Then you might need imaging and specific blood tests. If vitamin B12 levels are low, and particularly if an MRI of the spine shows damage in the posterior and lateral columns, these specific long tracts,
Yes.
then you're looking at subacute combined degeneration, a severe neurological consequence of B12 deficiency.
Wow, a vitamin deficiency causing such a profound walking problem.
It really highlights the importance of these pathways. And there's a third one, perhaps even more striking,
Go on.
Tabes dorsalis. This is a neurological complication that occurs years, sometimes decades, after an untreated syphilis infection.
Syphilis.
Yes, it specifically damages those posterior columns of the spinal cord carrying proprioception. You'd confirm it with syphilis blood tests and maybe checking the cerebrospinal fluid. It's quite something, diagnosing a chronic infection, partly by observing a stomping gait.
Okay, from stomping we move to steppage gait. The defining feature here, the sources say, is foot drop.
That's the core problem. The patient simply cannot lift the front part of their foot. They can't dorsiflex their ankle properly.
So if they tried to walk normally, their toes would just drag on the ground.
Exactly, they trip constantly. So to compensate, they have to lift their entire leg higher than usual, flexing excessively at the hip and the knee.
Almost like they're perpetually stepping over something or marching.
Precisely, high steps to ensure the toes clear the ground. That's the steppage pattern.
Now, when we see this, the sources suggest a key branching point is family history.
Correct. If there's a significant family history of similar walking problems, maybe high arches or hand weakness too, you have to strongly consider a hereditary neuropathy.
Like Charcot-Marie-Tooth.
That's the most common one, yes. Specifically, Charcot-Marie-Tooth disease type 1A. And we can confirm that nowadays with genetic testing, looking for a specific duplication on the PMP22 gene.
Okay, but what if there's no family history? Then we're thinking acquired nerve damage.
Right. Then it's likely nerve compression somewhere. The big question becomes, is it the nerve in the leg, or is it a nerve root coming out of the spine?
So peripheral neuropathy versus radiculopathy. How do we tell those apart?
This is where a careful neurological exam is crucial. If it's peroneal neuropathy, the compression is usually around the knee, where the peroneal nerve is quite superficial.
Ah, like from crossing your legs too much, or maybe a tight cast.
Exactly. Those are classic risk factors. The numbness or tingling would typically be on the outer part of the shin and the top of the foot. And the weakness is pretty localized to angled dorsiflexion, lifting the foot up, and a posturum gargen, turning the foot outwards.
Okay, so fairly localized symptoms matching the nerve pathway. How does that differ from an L5 radiculopathy where the nerve root is compressed back at the spine?
With an L5 radiculopathy, you might have similar numbness on the shin and top of the foot, and definitely the foot drop weakness. But patients nearly always report low back pain, often shooting down the leg sciatica.
Okay, pain is a big clue.
It is. And crucially, the weakness isn't just in the ankle. Because the L5 root supplies more muscles before it even gets down to the peroneal nerve, you'll also find weakness in ankle inversion turning the foot inward, and importantly, weakness in muscles higher up, like hip abduction, moving the leg out to the side.
So weakness in the hip tells you the problem is further back at the nerve root level, not just down by the knee.
Precisely. That hip abduction weakness is a key differentiator pointing towards the L5 root. It's a subtle but really important finding.
All right, moving on. Gait type 4, ataxic gait. This sounds like general unsteadiness.
It is. Ataxia essentially means incoordination, and when it affects gait, it usually points towards a problem in the cerebellum.
The cerebellum being the brain's coordination center.
Exactly. The gait is typically wide-based. They spread their feet apart for better balance, and it's often unsteady, maybe lurching or veering to one side. The rhythm and stride length can be quite irregular, too.
I imagine if it's mild, it might be hard to spot during just casual walking.
That's very true. Sometimes the ataxia only really becomes obvious when you challenge their balance more directly. The classic test is tandem gait.
Walking heel to toe like on a tightrope.
Right, asking them to walk in a straight line, placing the heel of one foot directly in front of the toes of the other. Someone with even mild cerebellar ataxia will likely struggle significantly with that, losing their balance or needing to step out of line.
And anatomically, within the cerebellum, is there a specific part linked more to gait problems?
Yes, that's a helpful distinction. The central part of the cerebellum, called the vermis, is primarily responsible for coordinating the midline structures of the head and trunk, and therefore posture and gait. The cerebellar hemispheres on the sides are more involved in coordinating limb movements, like finger-to-nose testing.
So significant gait ataxia often suggests a problem affecting the vermis.
Very often, yes, particularly if you also see truncal ataxia.
What does truncal ataxia look like?
Difficulty sitting or standing straight without swaying or needing support. Their whole trunk might seem unstable.
Okay, so if we suspect cerebellar ataxia, especially involving the vermis, what conditions come to mind based on the sources?
Well, a very common cause, unfortunately, is alcoholic cerebellar degeneration.
Due to chronic heavy alcohol use.
Yes. Over time, alcohol toxicity can preferentially damage the cerebellum, particularly the vermis. The exam shows the gait ataxia, trouble with heel-to-shin testing, and often that truncal ataxia we mentioned. Sometimes you might even see titubation, a kind of tremor of the head or trunk.
And imaging would confirm this?
Brain imaging, like an MRI, would typically show atrophy or shrinkage of the cerebellum, especially noticeable in the vermis in these cases.
Okay. What's the other main cause highlighted?
The other key one is hereditary. Friedreich ataxia. This usually starts earlier, in childhood or adolescence.
And how does this present differently, besides the age of onset?
It's progressive, involving not just ataxia, but also often significant sensory loss, particularly proprioception and vibration sense. So they might have features of both cerebellar and sensory ataxia.
Ah, interesting combination.
Yes, and crucially, Friedreich ataxia often comes with other systemic problems. Things like cardiomyopathy, heart muscle disease, or diabetes are common associations. On exam, besides the ataxia and sensory loss, you might see physical signs like scoliosis, curvature of the spine, or pes cavus, which is a very high arch in the foot.
And the diagnosis here is genetic.
Correct. It's confirmed by genetic testing, looking for a specific mutation in the phytaxin gene, an expansion of GAA trinucleotide repeats. So again, observing the gait pattern leads us down these very different paths, one acquired through lifestyle, one inherited genetically.
All right, our final gait pattern. Parkinsonian gait. This one feels like many people have a visual image of it already.
It's certainly one of the most recognizable. The classic features are that forward stoop posture, difficulty getting started, what we call hesitation or freezing of gait.
Right, like their feet are glued to the floor for a moment.
Exactly. And then when they do get going, it's with short shuffling steps, often accelerating. That's called festination.
And turning is difficult too, isn't it? They don't pivot smoothly.
No, they often take multiple tiny steps to turn around, almost like turning en bloc as a single unit.
So the most obvious condition associated with this gait is?
Parkinson's disease, PD, naturally.
Yeah.
And the gait is just one part of the picture in PD. You're also looking for the other cardinal signs.
Like slowness of movement.
Yes, bradykinesia
Mm-hmm.
and muscle rigidity, where the limbs feel stiff when you try to move them passively. And of course, the tremor.
The characteristic resting tremor, often described as pill rolling.
That's the one. Usually starts in one hand. And importantly for gait, people with PD often have postural instability.
How do you test for that? You mentioned the pull test earlier.
The pull test is key. You stand behind the patient, tell them what you're going to do, and give a quick, firm pull backward on their shoulders. Someone without instability will take 1, maybe 2 steps back to regain balance. Someone with PD postural instability might take multiple steps backward, or even fall if not caught.
And one more visual cue when they walk.
Ah, yes, very important. Arm swing. In Parkinson's disease, the natural arm swing during walking is typically reduced, often more on one side initially.
Okay, reduced arm swing is key for PD because the sources brought up another condition that can look similar gait-wise but is very different. Normal pressure hydrocephalus, NPH.
That's a critical differential diagnosis. NPH is known for its classic triad of symptoms.
Right. Cognitive decline, urinary problems like urgency or incontinence, and the gait disturbance.
Correct. The gait in NPH can also be shuffling, wide-based, and unsteady. It's often described as magnetic, as if the feet are stuck to the floor, requiring great effort to lift and move forward. Postural instability is also common.
So wait, both PD and NPH can have shuffling postural instability. How do you reliably tell them apart just by looking at the gait if the other symptoms aren't clear yet?
It's a challenge. But that arm swing observation becomes incredibly helpful. Remember how arm swing is decreased in PD?
Yeah.
Well, in NPH, the arm swing is typically normal or even exaggerated. It's a striking contrast.
Mm.
You might see someone shuffling with great difficulty, but their arms are swinging quite freely. That mismatch strongly suggests NPH over PD.
Wow, okay. Normal or increased arm swing despite a shuffling gait points towards NPH. That's a fantastic clinical pearl.
It really is. And the diagnosis of NPH is supported by brain imaging CT or MRI, showing enlarged ventricles, often out of proportion to any cortical atrophy, and confirmed by finding normal pressure during a lumbar puncture, sometimes with improvement in gait after removing CSF. Hashtag tag outro.
That was quite a tour through the neurology of walking. We covered, let's see, spastic, stomping, steppage, ataxic, and Parkinsonian gaits. 5 really distinct visual patterns.
And what's amazing is how each pattern immediately points you towards a much smaller, more manageable list of potential underlying causes.
Yeah, from the stiff circumduction of spasticity leading to spinal cord issues or CP, to the forceful steps of sensory loss and stomping gait pointing towards diabetes or B12 deficiency or even syphilis.
To the high steps of foot drop and steppage gait, making us think about nerve compressions or hereditary neuropathies.
The unsteady veering of ataxia linked to the cerebellum, whether from alcohol or genetics.
And finally, the shuffle of Parkinsonian gait and that crucial arm swing difference helping distinguish PD from MPH.
It really drives home how much information is contained just in the way someone moves. The human gait, as you said, it's like a neurological printout.
Absolutely. Careful observation is such a powerful diagnostic tool.
You know, the sources detailed all these serious conditions, infections, nutritional issues, hereditary diseases. But what really struck me was the steppage gait example. Something as seemingly minor as, say, habitually crossing your legs tightly or wearing a cast for a while can actually cause foot drop and mimic a more serious neurological issue.
That's true. External factors can definitely play a role or confuse the picture.
It makes you wonder, beyond these major diagnoses we've discussed, what other subtle changes might be happening in our bodies, and what small, maybe unconscious adjustments are we making in our everyday movements or posture, maybe even our gait, to compensate for things we haven't even noticed yet? Something to think about.